Ladies and gentlemen, today is my privilege to tell you a story from a clinician from the ICU to the GFN. Let I tell you about a little bit about me. For very first 12 years of my youth, I spent 12 years in intensive care unit where I have to take care of the patient with the end-stage disease of the COPD, acute myocardial infection, meningitis, and encephalitis. In this photo, you can see I am carrying a patient with a mechanical ventilator due to the COPD with a severe septicemia. And for this patient, the problems is who care about the quit smoking consultant for this patient. And I nearly forget the quit smoking consultant for this patient for 12 years. But after this time, I move into the internal medicine where I provide the health care for the patient with the diabetes, cardiovascular disease, depression, etc. And I recognize that quit smoking is a priority for daily practice of the GP, cardiologist, endocrinologist, internist, etc. And let I tell you a brief figure about the smoking epidemiology at Vietnam. You know, in Vietnam, we still a top country of the 15 countries with the highest prevalence of the world. At least 50% of the Vietnamese male are smokers, and it's really a heavy burden on the medical healthcare system of Vietnam. We have at least 100 people die every day due to smoke-related disease. 30 million people, particularly women and children, are the passive smoker. And every year, we have spent at least $1 billion for take care of the patient with the smoking-related disease. And that's why we carry out a lot of the anti-smoking program. But you can see in this slide, the result is very modest. Within 10 years, since the year of the 2001 to the year of 2010, the rate of the smoking just dropped at about 10%, 1% per year. The successful rate is very modest. And the reason of the 90% of smokers fail to quit smoking, I can enlist some common reasons. The cheap price and easy to buy. You know, in Vietnam, you can buy a pack of cigarettes very easy in every corner of the street or even in the supermarket. Nicotine replacement therapy is not accepted by smokers and even by the doctors, healthcare professionals, and because they still consider as a toxin. We lack of the minimum facility, psychology, counseling, NRT, bupropion, and Chantix. We lack inadequate, ineffective smoking cessation counseling. We just have 2 centers of the smoking counseling quitting at both big cities of the country. And the tax strategies is not good enough to reduce the people of the smoking. And at least in Vietnam, we have some harm reduction program. It's not the harm reduction concept is not very new at Vietnam. For example, for me it's very interesting. The current harm reduction of Vietnam, a typical example is we have a national program to replace heroin by free supplementation of methadone, a less toxic substance for drug abuser. In this program, the drug abuser have to go to the health station, receive a methadone, and take it in the supervision of the healthcare professional. And this program achieve a lot of the successful. They can reduce the number of the heroin abuser of Vietnam and this harmful effect for the individuals and society. But the problem is The question from my clinician is, heroin can. Why cigarette cannot be replaced by the least toxic products? And if we replace a cigarette by a least toxic product, is it effective to reduce risk of the lung and CV disease? And my question is definite answer from the publication in the Circulation, a very well-known magazine for the cardiologists. In this paper, Dr. Choi and his colleagues taking care of study for more than 5 million participants, and he compared the risk of the heart disease among 3 groups: quit smoking, continue smoking, and replace smoking by NRT. It is the result of the study. I think it's a very busy slide, and I would like to summarize the result of this study like this. The low with risk, of course, you can predict, is among the group of the complete combustive cigarette smoker. The high risk 1.5 hazard ratio is belong the group of the continued smoking, and the medium risk, reduced risk, is on the group quit smoking and convert into the nicotine TTP product. And for this slide, I can draw my our conclusion. NTTP not elaborate completely the risk of the combustive smoker, but at least they can reduce 50% the risk of the continuous combustive smoker. And another data, very valuable data, come from the study of the Japanese author. They predict the number of the patient admission due to the COPD after converting the heat-not-burn cigarette. You can see in this chart the admission rate of the COPD dramatic and significant reduce after they convert from the cigarette into the heat-not-burn. And similarity, the number of patient admission due to the cardiovascular disease has been reduced significantly after converting into the heat-not-burn product. And from this study and vast majority of other study, I can withdraw our clinical points for a clinician. Most of my patients have willing to quit, but fortunately 90% of them fail. It's not easy, very difficult to quit completely. And HTP can reduce medical risk for the patient of the cardiovascular and lung disease. And from this awareness, I do my action for the harm reduction voluntary based on my knowledge and my role of the medical lecturer in medical university. For example, I joined the Vietnamese Medical Association expert panel discussion. In this discussion, I show the benefit of the harm reduction of the heat-not-burn product despite the anti-tobacco consulting. I joined the Asian Federation of the Cardiovascular Congress with the other experts of the world to discuss about the heat-not-burn. I do the lecture for the young physician about the heat-not-burn product and harm reduction concept. And I joined the public show on TV, radio to discuss with the other doctors about how to reduce the bad effect of the smoking at Vietnam. And here is initial achievement. The perception of medical community is not very good. I recognize a majority of them is still in low awareness and acceptance about tobacco harm reduction. They still misunderstanding nicotine is high toxicity and should not use for harm reduction. And they suspect me and other experts who share the same ideas is the mass advertisement of the cigarette is very sad and also very funny too. And at least there is a small group is very convincing and asked me after my lecture about further information about IQOS, unheated tobacco has been smuggling selling in Vietnam. And I cannot ignore about the perception of my patients, who is the highest priority in my medical service. Let I tell you a story about Lisa. She is my long-term patient, and she is an American writer, chain smoker with heart disease, diabetes, obesity, and depression. She knows well she is very high risk on this disease, but she cannot quit because she is highly dependent on the cigarette. You can know she smokes at least 2 packs of cigarette every day. And after be convincing and quit into the heat-not-burn product, she feels significant improvement in general health. She is happier, better mood, not fall into the attack of the depressive and anxious attack. And in verbal, she highly appreciates my advices for converting from to heat-not-burn product, and she called heat-not-burn product is a game changer not only for her but for the world. And finally, I would like to mention a little bit about reduction of Ministry of Health in Vietnam. In Vietnam, Ministry of Health follow the WHO, and they has not adopted tobacco harm reduction approach, and that's why they are not happy about my activities. They send the warning letters for me and send the complaint to the leader of the hospital. They interfere about my public event about tobacco harm reduction, and they suggest canceling this activity. Or it's not a really obstacle for my individual efforts. But in future, my plan of action is still continue. I recognize communication is the first priority. Communication is very important. At least in my duty for scientific community, for healthcare professional, and the public via media. I try to convince the medical authorities that by ban harm reduction efforts, they should join transparent debates and urge them to find common ground in solution. And I start and continue my CME lecture for medical students, doctor, medical educators to show the data and convincing they spreading the concept of the harm reduction. And although of my effort and activities, even from my side, I still have some possible concerns. E-cigarette or NTP may increase tobacco and nicotine usage by renormalizing the act of smoking. And maybe the smoking, but the HTP may be fashionable and easy to be mimicked by the youth. And the NTP may act as a gateway for smoking for the young people. And NTP could be a barrier of the complete quit smoking. I have seen some of my patients after quitting, they try mix combustive cigarette and the NTP product to reduce the price and enhance the pleasure. It's a reality. And if a traveler, I have a chance to travel a lot through my country, I can see the thuốc lào. You can see it's a traditional smoker apparatus made by bamboo at Vietnam. It's very easy to do, easy to access, and very, very cheap. And it's still very common in rural areas and the minority. And the price of this is very, very cheap. And in this area, the problem of inequalities, how can this patient can reach NCT with our policy of the national level, if with the proper price, with the medical education, with the understanding and with the supervision of the medical professional. Thank you very much for your attention to this matter.